So those were four wonderful talks. I'm sure they didn't have time to cover some of the aspects. I just thought I will share a few of the things that maybe were not covered. So these are the four speakers you heard today, and wonderful talks. I really learned a lot from each one of them. So the first talk was about genetic polymorphisms in DLBCL, and Manju gave a fantastic talk with beautiful slides and pictures. So actually what genetic polymorphisms mean typically is that there are variants in an individual genome that are constant throughout the person's lifetime. And these actually contribute to the variability in the drug pharmacokinetic and pharmacodynamic processes. Manju, to a large extent, confined herself to the tumor tissue itself. So I'll just share a few of the things that what actually genetic polymorphisms mean. So do we have polymorphisms that could make a person susceptible to DLBCL? And this is one study that I got looking at a particular gene polymorphism, LAPTMB4B. And this actually looked at the overall survival and disease-free survival for this specific polymorphism. And this was for 1 and 2. And they found that there was a difference, in fact. They looked at for IPI 0 to 2 and 3 to 5, and it seemed to be much more significant when the IPI was worse. So they concluded that the risk was slightly increased in cases with the M4B1 genotype as compared to the 1-1 genotype. And there was no significant association of the two allele overall survival and disease-free survival. And one of the conclusions was this number was, of course, small. And this seems to be an independent prognostic marker, especially for the IPI scores, which are 3 to 5, which I showed you earlier, that they have a longer overall survival and disease-free survival. The other genetic polymorphism I got data was for the glutathione S transferase, and this was detected in this cohort of 136 patients in about 47.8%. They were heterozygous in 42% and homozygous in 10.2%. And it seemed to be that this particular polymorphism is associated with unfavorable prognosis. This was just presented as an abstract, so the full paper is not yet out. We heard a lot about the treatment aspects that are there, and this is a paper on polymorphism of the CD20 gene and the relevance to the clinical efficacy for the treatment that we generally use, which is R-CHOP. And they showed that if there was a genetic polymorphism in the CD20 receptors, it did have a correlation with progression-free survival and overall survival as well. And it seems that this is an prognostic factor that is independent of the molecular subtypes. We heard a lot about GCB and non-GCB, but this seems that it is independent of either of these molecular subtypes. So that was for the genetic polymorphisms, and I don't think I need to touch anything more after Dr. MBA has spoken so extensively. Also for the primary mediastinal lymphoma, which the topic was for the dose I just spoke. But one important thing, again, because we are talking of genomics, I thought I'll just share this with you, that this was one paper which appeared in Blood last year. And they actually did a comprehensive genomic analysis. And this actually showed that there was, in fact, a genetic driver, which was identified as ZNF217, and the high mutational burden MSI and APOBE6, which stands for apolipoprotein B mRNA editing catalytic polypeptide-like gene. And this signature was important because, as Dr. Su told you, that we are looking at PD-L1 blockade as a potential form of therapy. So that was about primary mediastinal B-cell lymphomas. Polatuzumab, you've already heard enough beautifully from Vamshi, and this is just a repetition of those slides. And this is sort of a summary slide showing you all the development program that's happening in NHL using this particular molecule. And quite a bit of this Vamshi already showed, and there are actually studies which are combining, in fact, atezolizumab as well. And these are the studies for you. I think we need to wait for these results to mature. So this is the summary slide. Why we did all these talks was for us to incorporate all this into our patient of DLBCL so that the outcomes are really good. So with that, I will stop and let us start taking questions. I think there are quite a few of them. So the first one is from Krishna. Is the treatment different for DLBCL GCB versus DLBCL non-GCB cell types? Maybe uh, Dr. MBA, you can take this.
The first question, is it generally DLBCL
Yes.
is potentially curable, but still some setting it's aggressive in nature and relapses early? Why still immunotherapy is not working in DLBCL despite nivolumab is better drug in Hodgkin lymphoma? Is that the question you're putting to me?
No. This is treatment different for DLBCL GCB versus DLBCL non-GCB subtypes. This question has come at 10:50 this morning. No, in fact, night.
From Krishna, is treatment different for DLBCL GCB versus non-GCB type?
Yeah.
So I don't think at the moment we can make this kind of differentiation. People have tried their best, but I don't think we have been successful. So I will say no.
Okay. This question is for Manju. Is there any genetic or molecular profiling for or genetic studies to find out prognosis in DLBCL at starting of newly diagnosed patients?
So as of now, what is recommended is, you can do FISH for c-MYC. That's the only thing which is being done. However, meaning if the center has, facility for doing NanoSpring and LIMC2X, you can do it only for academic purposes, because as Dr. Agrawal said, the treatment does not differ at this moment whether you find out it's a GCB or a non-GCB DLBL. But if you want to keep the data, you want to have better prognostication, that's the only thing you can look at through GP. Regarding the double hit, there is a difference in the treatment, and even for the MYC positive DLBCL, there is a difference in the treatment as opposed to just giving R-CHOP. So probably that's the only thing which will help.
So again, Manju, this is from Dr. Smita. She's asking if for double hit, is it better to use DEPOC as compared to other regimes? Maybe you can take this as well.
Sure. So the data on double hit lymphoma is largely retrospective. All these studies which have looked at double hit lymphoma have compared aggressive regimens versus R-CHOP. And REPOC turns out to be a winner in terms of better response rates and better progression-free survival. We are not sure whether it's clearly the answer, but having the limited data, as of now, this looks like the treatment of choice for double hit lymphomas. There's some data from MD Anderson regarding hyper-CVAD, doing as good as REPOC in terms of responses and the outcomes. But as I said, that's a single center data. Unfortunately, many a times, most of the other centers outside MD Anderson have not been able to replicate the data with hyper-CVAD. So given the situation that most of us have become now very comfortable using REPOC, I would suggest that will become the treatment of choice.
Okay. The next one is from Dr. Madhusudan again. How do you go for bone marrow transplant in the present COVID-19 situation with mantle cell lymphoma who's achieved remission after 8 cycles of chemotherapy? Patient is 55 years young male, radiologist by occupation, and at present receiving only rituximab. So I think Manju, since you've been seeing the COVID-19 patients as well in TMH, maybe you can take this.
So we are in a special situation because a lot of our beds have been converted to COVID beds, and currently almost 100 patients are inside. So our resources are limited for the non-COVID patient. So as of now, we have kept transplant on hold. Only the non-transplant therapies are going on.
Actually, ESMO has brought out a beautiful statement, and it is a spectrum of high priority to low priority, and that gives the various treatments that you can keep them at low priority and high priority. So that is a good paper for you to look up to actually guide your treatment for your patients.
Yeah. So absolutely, it all, as Sir said, that they have prioritized, and the prioritization all depends on the disease nature as well as which
Exactly.
situation you are in as far as pandemic is concerned. So if somebody sitting in Bombay can't tell the same, implications are there for somebody who's sitting in Kerala, because things are entirely different. So you need to look at both, and as Sir rightly said, please refer to that paper. It really gives you idea about prioritization as in the current era.
Absolutely. So this is another from Dr. Ramamurthy. It's a long question. Oh, the question disappeared.
It is there.
Okay.
A long one, yes.
Yeah. So I think this is a long question. We'll email it to one of the speakers, and then maybe we'll email the detailed answer to this, because Dr. Agarwal, I don't know how much time we have to take the questions.
We have some time.
Okay, because if you're not able to finish all of them, then maybe we can get their emails and personally send them the answers. That would be okay, I feel. This is a question from Dr. Sharma. Based on the data, again, this question jumped.
Will you select?
Okay, this is from Dr. Madhusudan. How do you go about a patient having one pathologist saying 3A lymphoma and other pathologist saying 3B lymphoma in asymptomatic patient? Go to the third pathologist. No. Manju, I think you can take this because you come from a large volume center, and maybe after that, Dr. Agarwal can say his, can I put his
means I can understand this problem can arise if you're looking at a core biopsy where, at times this distinction can become difficult. So I would suggest that definitely have a review, because the management is going to be different. But if you have a 3A, it means if one pathologist has reported a 3A, but you have high LDH and high SUV max there, and you can't get a biopsy where you can't get an excisional or an incisional biopsy to get a clear picture on the entire lymph node architecture, then in that case it's better to err on the side and treat them like a 3B lymphoma. So you need to look at the entire situation, the bulk of disease, the LDH, the SUV max, and if you can't get a review and can't get an additional biopsy, then in that case it's best to treat them as 3B.
Okay. This one is from Dr. Vidya. Could you kindly share the important genes required for DLBCL in today's management? Would you like to have fusions, mutations addressed in the same panel? Manju, maybe you can take this.
So as we said, that it all depends on where you are and what you are doing. If you're purely looking at from the academic purposes, and if you have means for doing the nanostring or other GP, please go ahead and do that. There are different panels. If you look at lymph C2X has a different panel which can be done. If you're in a setting where you are purely delivering the service, as I said, that you just need to have a morphological and immunohistochemical diagnosis of DLBCL as of now, and have the clinical parameters to calculate the IPI, and that would be good enough as of now, rather than doing any genetic profile. If you have means for doing FISH, as we answered earlier, do a CMYC FISH, and if positive, then in that case, do a BCL2 or a BCL6 by FISH. So this is all I would suggest. It all depends on where we are.
I think that answers Dr. Mona's question as well about concordance of gene expression profiling with IHC FISH to determine cell of origin. Okay. The next one is from Dr. Humairu. Should RLI be given concurrently with CHOP from the very beginning, or first cycle with RLI and then 6 cycles? I think Dr. Agarwal described beautifully the whole protocol and what was done. Maybe Dr. Agarwal, you can just clarify the same thing again.
Okay, so the idea was to avoid chemotherapy in the beginning.
Yes, that's right.
So RLI was given for 2 cycles and then 6 cycles of CHOP together with RLI.
Okay.
Over to you.
This is from Dr. Akhtar. What is the best chemo option for de novo GCB DLBCL in young patient and in elderly group? So again, this Dr. Agarwal, you can take this.
Well, as far as young people are concerned, there is no much discussion. R-CHOP remains the standard of care. Elderly group, it will depend. Now, they may be cardiac fit, they may not be cardiac fit.
Okay.
If they are cardiac fit, you will not like to avoid adriamycin. And if they are compromised, the mini CHOP, the R mini CHOP, where still adriamycin is there, will be the preferable regime. But if you are not able to use adria at all, then we replace it usually with the etoposide. That has been the protocol for otherwise relatively fit people.
This is from Dr. Gunjan, and she's talking about using NGS in clinical practice. I think, Manju, you already answered this question, that it depends on what you want to do. Maybe you can clarify it in another couple of lines here. NGS in your clinical practice for DLBCL patients.
So as I said, that we are not recommending an NGS in the clinical practice, regular clinical practice. If you have a good research laboratory and you want to have prospective data maintained, then in that case, you can do either danostring LIMC2X, or you can have, so like for us, we have devised another panel for DLBCL for looking at GCD versus ADC, but that's again a homegrown kind of a panel. So as I said, that I don't have a evidence, clear evidence as of now to say that everyone should start doing NGS. What I meant in my talk was that from now onwards, whenever somebody is planning clinical trial for R-CHOP plus kind of a situation, given the genetic heterogeneity, it's very important to enrich these populations, stratify them, enrich them based on the biomarker. And as you know, very clear from these Smart Start trial, that you cannot just have one drug and target one mutation here. You need to look at pathways which are overexpressed, and then go ahead and plan the clinical trials based on that. But for clinical practice, as of now, I won't suggest that any NGS is needed for your clinical practice.
Yeah, that's right. I think like we do in non-small cell lung cancer, we have not yet reached there in diffuse large B-cell lymphoma, but I think with evidence gathering, we probably will be going that way in the future. So this is from Dr. Dilip. What is the toxicity profile of RLI when added to R-CHOP? Will it be tolerable for Indian patients, especially with a dose of 560 mg of ibrutinib? Dr. Agarwal, I think you're the best suited to take this question.
So I think we discussed the toxicity profile, and we talked about both hematological toxicities, non-hematological toxicities. We talked about their grading. So as far as you are concerned about the dose of ibrutinib, then you do have the problems which are skeletal-muscular pain, bruising, atrial fibrillation, fatigue, diarrhea, hypertension. So you have to be ready when you're using ibrutinib. And as you saw, one case even had aspergillosis in their series. So the standard things that have been described about ibrutinib, we have a larger experience in CLL rather than in RLI in DLBCL. But I don't think that the differences will be there. Same thing applies to lenalidomide. All other drugs you are already used
to. Again, Dr. Agarwal, this is for you from Dr. Naresh Somani, who says whether you would routinely use RLI, R-CHOP in a young fit patient.
So it is an exciting protocol, but we must remember this is phase 2, limited number of patients, single center. So all those things which are one criticizes for a single center, small study phase 2 still remain applicable. Maybe wait and watch for a while.
Okay. This is from Dr. Raghavendra. It's talking about, will mass spectroscopy instead of gene profiling help identify chemical differences in different lymphoma cells to isolate chemicals to treat lymphoma? I don't know who will take this question, because I don't think...
tell you from the angle of amyloidosis.
Yeah.
That mass spectrometry is a mandatory test there to know the type of amyloidosis. And when I inquired all around, it seems there is not a single center offering you the clinical service. So it's totally theoretical to us.
All right. So the other question is about managing double expressor and double hit. I think Manju already discussed this. So let's go on to the next question. This again from Dr. Gunjan. Is there any extra measure to follow while dealing with neutropenia in a patient of RLI therapy? And about dose reductions to be followed. So Dr. Agarwal?
I didn't get this question. Can you read it again?
This is about toxicity or neutropenia with RLI and dose reductions that need to be followed.
I mean, yeah, I mean, they were grade 3, grade 4, and one case of ACE saw grade 5.
Yeah.
So standard care will have to be taken, sure.
Okay. This is from Dr. Rajeshwar Singh. I have a 72-year-old refractory DLBCL non-GCB after R-CHOP, R-Lenalidomide, and Ibuprofen. Try RLI plus chemo, that is a smart start. So this again is for Dr. Agarwal. I think this was initially, yeah.
Smart start has been only tried upfront.
Correct.
Absolutely no data for the relapsed patients.
Yeah, correct. Initial RLI was for refractory, but not the smart.
Okay, yes, sure.
That's right. Okay. This is diagnostic markers for primary mediastinal. I think Dr. Sood very nicely has given all that. This is from Dr. Shekhar Patil. CNS prophylaxis in primary mediastinal B-cell lymphoma. Is there a role? Dr. Sood, can you take this?
Yeah, sure. So, I mean, as I mentioned, upfront primary CNS lymphomas are usually localized diseases. So they come under the low IPI score. The standard guidelines for CNS prophylaxis would mean very close to the nervous system or with a high LDH or testicular breast involvement. So I don't think there is any requirement for a CNS prophylaxis for this category.
Okay. This is to Dr. Manju from Dr. Ajay. Can you tell us what is the minimum test that we need to have as on today to manage DLBCL in India? Manju?
Yeah. So as I said earlier, that we need to have a morphological diagnosis with immunohistochemistry saying that it is CD20 positive and morphologically fitting with DLBCL. As well as if you have means, then we can look at one of those IHC algorithms to classify into GCB and ABC as per the WHO 2016 classification. And that's it. If you have means for FISH, go ahead and do the FISH for MYC and BCL2, BCL6. That's the only thing which is required. But if someone does not have means for FISH, I think a morphological diagnosis with MIB index with CD20 positivity should be good enough from therapeutic purposes.
The next question is from Dr. Dalal. Is bone marrow involvement documented? If bone marrow involvement is documented in primary mediastinal B-cell lymphoma, how should we differentiate it from systemic DLBCL? Is there a genetic workup that can help? Dr. Sood?
Yeah, thank you. So that's a very important question. Now, PMBCL, any mediastinal lymphoma should be differentiated from standard DLBCLs and from Hodgkin's lymphoma to be sure that we're not dealing with something else. Bone marrow involvement is very rare, especially in upfront DLBCLs. Whatever bone marrow involvement we see is in relapsed PMBCLs. And the other one was, sorry, I missed the question now. If there is no molecular markers available, you could do IHC to find out. Of course, morphology is the first step. Plus, coupled with IHC, IHC is very different or somewhat different to DLBCL, somewhat closer to Hodgkin's lymphoma. So all the B cell markers are present. CD20 is present. And there are some other markers like CD30, which are usually there in Hodgkin's, are weakly expressed in PMBCLs. There is the BOB1 protein, the MAL protein in case you're in doubt, and CD200 in case you're in doubt, but you may not have access to all these. Of course, molecular studies remain the end point in very doubtful cases, but generally if you do all these IHCs, then you will be able to differentiate.
Okay. This is to Dr. Vamshi. Is polituzumab available in India?
So right now, not available in India. I believe they will try to launch it soon. More importantly, I think you can try to get it on compassionate access. You can write to Roche if you have the right patient. So you can try that. I know somebody has done it for a patient. So you can try.
I know. If I can just add to that, Roche is offering compassionate access to various centers. And you'll have to kind of stick to the guidelines to say that the patient has to be non-transplant eligible. So it's not available outside the recommended indication.
Correct. They're approved indications only. Yeah. Okay, Vamshi, you can take this from Dr. Shekhar Patil. Is polituzumab have any benefit with CD5 DLBCL, CD5 positive DLBCL?
I really don't know the answer to that because I'm not sure that segment has been actually tested separately. So I really don't know the answer to that. Maybe Dr. Agarwal or somebody can shed some light on
Dr.
it.
Agarwal?
No, I am not aware of this.
Manju, any idea? Okay, so I think Shekhar Patel will not have an answer.
Sorry, sir, I missed the question.
Role of polatuzumab in CD5 positive DLBCL.
So nothing specifically in this particular subset. I mean, they do poorly, so that's all, but nothing specific. They just been tested in CD5 positive DLBCL specifically.
Okay. So this is from Dr. Ravi Jaiswal. This is to Dr. Vamshi. Should Pola BR be compared directly with high dose and autologous stem cell therapy in the first relapse?
I don't see any reason to compare because the testing has been done in an autologous refractory case.
Yes.
Benefit. Probably one thing you can do is the conditioning regimen, it might be transitioned at some time into the conditioning regimen. So like our eyes with Pola is what has been already tested. So I think that's where it's going to go.
Okay. This is from Dr. Jayant, who asks a question about treatment of primary pancreatic DLBCL post-surgery. They've done Whipple's stage 1E. Dr. Agarwal? Maybe. Hello?
So
can you hear me?
So your voice was breaking. Hello?
Oh, okay. Yeah, this is about treatment of primary pancreatic DLBCL post-surgery.
And
Hello?
no other site of disease. That's the only site.
Yes, they've done a Whipple's.
Yeah, so then it has to be treated like a limited stage diffuse large B-cell lymphoma. Surgery alone is not enough. We need to go ahead and give systemic therapy, like a limited stage DLBCL, R-CHOP, and probably you can think of abbreviating chemotherapy here. So that's one. Otherwise, treat just like limited stage DLBCL. No radiation would be required because though it's an extraneural site, but you've done the surgery, so no radiation definitely.
Okay, Manju, since you're online, maybe you can take this. This is from Dr. Krishnaratnam, Chennai. What is the role of interim PET in treatment of DLBCL?
So you want me to take it?
Yeah, sure, Manju, go ahead.
So if you look at data for interim PET, means it only has a prognostic relevance unless it shows the progressive disease. That's the only situation where you would consider doing a biopsy and changing therapy. Otherwise, as of now, it has only prognostic implication. Though there are trials which are trying to see whether you can avoid giving radiation in patients who have a disease which where they have experienced complete metabolic response, but that's not the standard of care as of now. So it's only prognostic value at present and change of therapy if you have progressive disease.
Okay, I think the other one about CNS prophylaxis has already been answered. This is from Dr. Pramod Das. Would you recommend NGS in DLBCL? I think Manju, you have already answered this, not in routine work. Okay, this is from Dr. Dalal. How do you treat residual mediastinal mass post dose adjusted epoch? This is to Dr. Sood.
Yeah, so that's an important question. I mean, the other controversial area in the PMBCL treatment is the role of PET scan in assessment of disease response. And there's a lot of data to suggest that if you've got more than dual 3 in the residual setting, unfortunately, a lot of patients or majority of patients have dual 3 or less, then the chances of relapse and those patients do worse. So dual 4 and dual 5 especially do worse. So if you do have a patient who's had dual 5, then I think, and you've done dose adjusted epoch, then salvage therapy probably remains the only option. I would follow up for some time, but I think it's important to recognize and realize to look at the films yourself and make sure it's not an inflammatory mass, because inflammatory masses are fairly common after treatment for this sort of lymphoma.
Thank you, Dr. Su. This is to Dr. Vamshi. What is the role of polituzumab after CAR T failures?
Again, the data seems to support use of polituzumab before a CAR T cell. So you do CAR T cell and then the failure. I really don't know the answer to this. I think we have to wait and watch. I don't know the answer to that.
No, I think once you fail CAR T, it's largely palliative, isn't it?
Yeah, but again, if someone wants to use it in that sitting, I really don't know what to do.
No, I think unless you use another CAR T, I mean, if you face Decigen, then you can.
Correct.
And that's also not
Yeah,
proven.
we don't have enough data for that as well. Yeah, this is from Dr. Dilip Harindran. What should be the treatment strategy for an DLBCL that is transformed from follicular lymphoma? Vamshi? Transformed DLBCL from follicular lymphoma.
So the treatment should be within lines of a DLBCL itself, unless you have already treated the follicular before. I mean, I didn't get the question. Did he mean treated follicular before and now DLBCL?
Yeah, I think that's what I would assume, yes.
So we'll go with the standard treatment, go with the time of relapse, see how later it has been, go with the transplant if possible. I think that's what we would do.
And this is also an approved indication for CAR T.
Correct.
Yeah, that's right. Yeah. Okay, this is from Dr. Sajin Rajbandari. For a young patient with refractory retro-associated plasmablastic lymphoma post-VEPOC, what would be the other treatment options? Manju?
So as I understand, they've given bortezomib and APOC without vincristine, and treatment has failed. It all depends on what the CD4 counts are and what's the how the tolerance has been. If there are not many opportunistic infections, and this is the first line heart which is going on with the viral load under control and good CD4, one can think of going ahead and giving the salvage chemotherapy and if possible transplant. But if you have a situation where CD4 counts are low, the person has already failed first line ART and they are on second line ART with high viral load, situation is difficult here and it's unlikely that any therapy is going to work. So you need to start thinking in terms of palliation, radiation, depending on how extensive the disease is.
So I think we've finished most of the questions. Yeah, really, we've finished most of them. So Dr. Agarwal, would you like to take over?
Thank you, Dr. Govind Babu. We are on the dot. It's almost about 1:30, so we have not delayed anybody from their lunch. Well, it's just my job and the pleasant job to give a vote of thanks. I'm extremely grateful to the faculty, starting from Dr. Ved and right up to Dr. Govind Babu and all the speakers, all the audience. A huge number of you have logged in. Our service provider, Mice Ideas, and our sponsor, Reddy's Lab. So that's all what I have to tell you. Next Sunday, we have myelodysplastic syndrome. Do log in and have a wonderful lunch.